Welcome everybody. Let me present you my 12 months progress report of my PhD topic, Prognostic Factors of Serum Biomarkers in Urothelial Cancers. My name is Ádám Széles. I'm a resident doctor in Semmelweis University at Department of Urology. My vision is therapy optimization of urothelial cancers, and as a mission I would like to assess the utilization of different biomarkers in urothelial cancers treated with immune checkpoint inhibitors. These are my 3 ongoing projects where I will investigate different biomarkers in the aspect of urothelial cancers and immune checkpoint inhibitors. In my first project, we are investigating the prognostic significance of soluble PD-L1 and soluble PD-1 in human malignancies treated with immune checkpoint inhibitors. We are at the phase that we are just submitted this article to Cancer Immunology Immunotherapy. About the background, that immune checkpoint inhibitors are one prosperous drug. It's really a revolutionary drugs, anti-cancer therapies, and it's a really big hit because it resulted in a Nobel Prize in 2018. So how these drugs work? You can see here a T cell and the cancer cells, they're both expressing PD-1 and PD-L1 receptors, program-def ligand and program-def receptors. If they both, it binds together these 2 receptors, that causes an immune suppression. So if you block it with an agent, that causes an immune boost, so the T cell will more likely to kill these cancer cells. It sounds really promising, but what we can see in the reality is that immune checkpoint inhibitors are really effective, but for a relatively small rate of patients. So if we make a clinical question that these soluble version of these receptors as a biomarkers have a clear, well-defined prognostic value in human malignancies treated with immune checkpoint inhibitors, and as a PICO framework, we have all kinds of cancers who receive this therapy. We are comparing different concentration, low and high concentration of these biomarkers, and outcomes are cancer-related outcomes like overall survival and progression-free survival. We did the systematic search in the 4 following databases, and it resulted 16 eligible studies. About the results, here you can see overall survival, one of the most important cancer-related outcomes, and in these forest plots you can see that we made the subgrouping based on the type of cancers. And what you can see that the heterogeneity is quite high, but it can come from many reasons because we are comparing different kind of cancers. These cancers are in different stages, the cohort size are quite different as well. And what you can see from the number is that if the hazard ratio is less than 1, like in esophageal squamous cell carcinoma, that means that high biomarker level is a protective factor, meaning that these patients have better survival rates. If the hazard ratio is higher than 1, like in non-small cell lung cancer group, it means that the high biomarker level is a risk factor, meaning that these patients have worse survival rates. The overall hazard ratio is 1.67, meaning that these patients with high biomarker level, 67% more likely to have worse survival rates. However, you can see in the subgroup it differs. The next outcome is progression-free survival. We made the same kind of subgrouping with the same heterogeneity problem, and what you can see here that the overall hazard ratio is 1.20, meaning that patients who have high biomarker level, 20% more likely to progress on immune checkpoint inhibitor therapy. Here, a secondary outcome, we assess the changes of soluble PD-L1 levels during the immune checkpoint inhibitor therapy, and what you can see here is that it's really interesting that only anti-PD-L1 antibodies cause the really strong elevation of soluble PD-L1 level. The strength of this study that this is the first study in this topic, and we have significant number of articles. However, we have some limitations that the heterogeneity that I just described. We have half retrospective and half prospective studies, and the cutoff values are different within the individual articles, and they used different ELISA kits. The conclusion is that soluble PD-L1 could be a useful pretreatment prognostic biomarker. However, the prognostic value of soluble PD-L1 seems to be different around various cancers and should therefore be interpreted in a tumor-specific context. And this indicates that soluble PD-L1 might have a cancer-specific prognostic value. The implication for practice is to use these biomarkers, and implication for research is that these on-treatment flare-ups needs to be further evaluated. In my second project, which title is High Pretreatment Soluble PD-L1 is associated with muscle invasion and shorter survival in upper tract urothelial carcinoma, we are investigating the same biomarkers, but in this rare tumor entity. We have recently submitted this article to Biomedicine. As I described, upper tract urothelial carcinoma is a rare disease. It only takes 5 to 10% of all urothelial cancers. And I would say that in this project, there are two separate ways. One is that preoperative biopsy has only a limited value determining the exact stage of this tumor. So this is rather a prognostic type of question to find the prognostic preoperative biomarker. The second one, in the much advanced metastatic cases, the question of what kind of systemic agent should we use, chemotherapy or immune checkpoint inhibitor, is rather a therapy predictive question. This is our cohort. We have 65 patients, which sounds small, but as I mentioned, this is a rare disease. We have 3 groups, a surgery group, a chemotherapy, and an immune checkpoint inhibitor group, and we did the biomarker analysis with sandwich ELISA. About the results here, you can see that we compared the preoperative serum PD-L1 concentrations and clinical pathologic parameters. And what you can see that in the we found significantly but overlapping but higher concentration with higher grades. We also found that there is a significant and there is no overlapping concentration with higher pathological stage, a muscle invasion, and in the metastatic group there is also a higher pretreatment concentrations. And what you can see here is that really similar to the meta-analysis, because we compared the pretreatment versus the on-treatment or post-treatment levels of soluble PD-L1, and what you can see that there is a mild post-treatment, post-surgery elevation. Significant, but it's really mild. There is absolutely no significant elevation in the chemotherapy group, and what you can see that also it's that anti-PD-L1 immune checkpoint inhibitor caused a really strong, almost 25-fold increase of soluble PD-L1. In the survival analysis, that we found that in the surgery and in the chemotherapy group, there is a significantly worse survival rate with patients who have high biomarker level. The strength of the study is the cohort size. As I mentioned, 65 sounds small, but this is a rare disease. The prospective design, and we have different treatment setting, and this is the first article in this project. However, of course, we have some limitations that we could not make a correlation analysis of the tissue PD-L1 and the serum PD-L1 levels, and the cohort size in the immune checkpoint inhibitor group did not allow us to make a survival analysis. Therefore, we don't have question to the therapy prediction, as I mentioned. And about the conclusion, the soluble PD-L1, it could be a useful preoperative prognostic biomarker in upper tract urothelial carcinoma because we found significantly higher concentration in much advanced pathological stages and the presence of metastasis. The implication for research is to use these biomarkers in pretreatment treatment optimization, in risk stratification models, and the implication for research is that these on-treatment flare-ups, as in the meta-analysis, needs to be further evaluated. And I just want to give some quick talk about my third ongoing project where I will start now on. This time we are investigating the prognostic significance of neutrophil to lymphocyte ratio, platelet to lymphocyte ratio, CRP and LDH, but this time in urothelial cancers, but again we have restriction to therapy immune checkpoint inhibitors. About the background that bladder cancer is among the top 10 most prevalent cancers in the world, and when it is metastasized, it has a devastatingly low 5% 5-year survival rate. And this time we have to give some kind of systemic agent that can be either platinum-based chemotherapy and again immune checkpoint inhibitors. So the aim of this study is to highlight the importance of different inflammatory laboratory parameters which are widely accessible to use in clinical decision making. The PICO framework that will look like really similar to the previous meta-analysis. And I will start it now on because I've just submitted these 2 articles. And I would like to thank you for your kind attention with the words of author that I disapprove of what you say, but I will defend to the death your right to say it. Thank you very much.
I mean, this is very interesting, and some part is almost philosophical. I mean, besides doing the treatments, I mean, when you interfere with this kind of inhibitors, in the human body, I mean, on the biological side, in the human bodies, when you interfere with certain kind of mediators, some others are going up and down. So for this reason, it would be good to have a combination of different treatments. I don't know if really clinical research are at that point, or do you aim that?
You mean that if there is a combination of immune checkpoint inhibitors and other drugs?
Yeah.
If it's, for example, improves survival, or...
Yeah.
Well, for example, in renal cancer, that not in Hungary but in other countries, they are combining PD-1 inhibitors with the previous tyrosine kinase inhibitors, and that improved the survival rates. However, in some cancers, they only give it as itself, immune checkpoint inhibitors. So yes, but there's a lot of clinical research to combine different kind of therapies. But the biggest question about immune checkpoint inhibitors is that why we see that some patients are really lengthen the survival rates, and some patients it's just almost nothing.